we can sell you on the idea that you are outside of normal on this particular lab. But in fact, that lower value may actually be more optimum for you. You may take a supplement, get your value into the normal range, and do worse because your abnormal lab may have been more optimum for your health. That may just be how your body is set up. All right, so this is a topic that I have been excited to put together. I think it's led me down some interesting avenues, and it's something that I don't think is considered or discussed very much, and that is, where do normal lab values come from? How do we know if your lab test is in the normal range? And if it's on the high end of normal, or it's on the low end of normal, or it's exactly in the middle of normal, which one's better? Is there a better? Is that the right way to think about lab tests? So another way to think about this is, if we developed a new lab test, how would we decide what was normal, what was optimal? And how could we use that for health? Should we use lab tests for promoting optimal health? That's an interesting question. I think the answer is no, but I'm going to try and make my case here by starting by discussing where these normal ranges even come from and how to interpret blood work in that context. So, briefly, where normal values come from is, we find people who have no known medical problems. They're healthy as far as we can tell. Relatively young or middle-aged. In many cases, historically, these have been white males, so there's some questions there that we're going to get into. But we find apparently healthy people, and we test 1,000 of them, or 10,000 of them, or however many. And their lab values fall on a bell curve. So that bell curve shows you where the average is, and it shows you where the 95th and 99th percentiles are. And basically we pick, we say, well, if you are inside of the 95th percentile, or the 99th percentile in some cases, then you are in normal range. If you are outside of those, then your lab test is abnormal. Now, the interesting challenge here is that even in the sample group where we are establishing this normal, some people are on the far edge of that bell curve. Some people are abnormal according to the future definition of normal. But we picked them because they're apparently normal. So to get into this, let's start by considering body temperature. We all know, or think we know, that 98.6 is normal and 100.4 is a fever. And we don't stop to consider, well, where did that number come from? And in fact, that number comes from a single study that was done in 1868. And that has been the definition of normal temperature and fever ever since. Exactly the way that we described, is we took a bunch of people, measured it, found a bell curve, said above the 95th or 99th percentile is abnormal. Now, if we get more detailed than that, well, you can see that here in this chart, the normal, healthy adult human has a body temperature that changes over the course of the day. So here in this, they took a bunch of people, they measured their body temperature at different times during the day, same individuals, and then they averaged each individual's body temperature per time of day, and they were able to generate this kind of a curve. So at night when you're sleeping, your body temperature drops by quite a lot, almost a full degree. And if it does not, you actually will have trouble getting into deep stage 3 sleep, and you will not get the same restorative sleep that you would if you were able to get your body temperature to drop. That's why we recommend colder sleeping temperatures or chili pads or some other way of making sure that you are able to drop your body temperature. Your body temperature also rises above its average around 5 p.m. and then declines back down. So every individual has a normal variance through the day of nearly a degree and a half. Now, if you take all of those temperatures that were measured and ignore the time of day, and instead you just plot those temperatures on a graph, you'll end up with, just as I described, a bell curve. Now, the average temperature in a recent study is actually not 98.6, it's 97.7, and that's interesting for a number of reasons. We've been seeing worldwide, even in non-industrialized areas, a decline in the average human body temperature has been occurring generation by generation. So we don't have an explanation for that, but we do know that the average body temperature seems to be going down. And some medical societies have raised this as a question: is should we redefine normal body temperature? Should we redefine what a fever is? Because a fever is an increase of average body temperature. But another question is, well, if I'm one of these people who has an average body temperature, if you take my course through the day and you just ignore all that and just take the average for me, and my body temperature average is way out here on the edge of the bell curve at 100 degrees, well, a fever for me shouldn't be until 101. And by contrast, if I'm on the far other side of the bell curve and my average normal body temperature is 96 degrees, well, then even 98.6 should be a fever for me. So there's this interesting question of individualization. And we're going to get into that even more in depth in the next section. But normal body temperatures, we know, vary by gender. Women tend to run a little cooler than men. It varies by age, and the same individual at different ages will have different body temperatures. It varies by the area of the body that you're testing. So we usually do an oral temperature check. That's sort of the standard. But a core body temperature or a rectal body temperature are considered more accurate in medical circles, but they also have different norms. And then once you've been thinking about body temperature, well, what about blood pressure or heart rate? And we're going to get to those actually in the next video, because what we find is that for medical diagnostic purposes, we don't always just stick to this bell curve. We start sort of massaging the numbers in order to promote treatment effects. So a normal blood pressure is partly determined by treatment targets. A normal blood sugar, or an abnormal blood sugar for diabetes, is defined by the consequences of having that blood sugar. So even if the population overall, the bell curve may shift, but if we're defining it according to when we start seeing deleterious effects on health, and that's our definition of abnormal, then that's a whole different ballgame. But we'll get to that in part 4 of this series. So moving from body temperature, the next thing we're going to talk about is hemoglobin. So if your hemoglobin, that's your blood count so-called, is low, then you're anemic. And if it's high, then we call that polycythemia. And we know that high hemoglobin, if it's too high, puts you at risk for clots. And anemia obviously puts you at risk for shortness of breath, fatigue, and all the side effects of being low on blood, poor athletic performance, so on and so forth. So again, this is a 95% interval. We took a sample of apparently healthy people. We said anything below 2 standard deviations or above 2 standard deviations is going to be declared abnormal. Now, The problem, of course, is that we know that women usually have a lower blood count than men. So we said, well, we'll segment that out. We'll take women and men, and then we'll have different bell curves for them. And so the female normal is 12 to 15, male is 13 to 17, plus or minus. But of course, when women get pregnant, the average blood count or the normal blood count varies by trimester. So we said, okay, well, actually, we can segment that out into different bell curves according to trimester, the first trimester, second trimester, third trimester, and monitor, and those will be our normals. Now, as I've mentioned, the original studies in a lot of these things were done in white men. So what about other races? What's the bell curve for African Americans or for East Asians or for South Asians? Are those curves different? And then if you have someone who is a child of mixed race parents, which curve should you apply? Now, we also know that your hemoglobin can change according to your athletic status. So if you exercise very, very intensely, your body will push fluid into your muscles and pull it out of your blood vessels. So your blood will be a bit concentrated, and your body will react to that by retaining fluid, so that then when you rest, when you are recovered, you can apparently have anemia. It's called athletic pseudoanemia, because it's not a real anemia. It's just so that your blood keeps flowing when you have that shift of fluid from what we call the intravascular compartment into the intracellular compartment as a function of exercise. By contrast, athletes who train at high altitude, so people who will go to Denver and run and train there, the pressure of oxygen is lower there, and so they will be training under conditions of slight hypoxia, and their body will produce more blood to transport oxygen, increase their hemoglobin to transport oxygen to their muscles. And so this is a method of increasing their blood count. So how do we account for those with bell curves? Should we have different bell curves for athletes that have a certain VO2 max? Should we have different bell curves for athletes who train above a certain altitude? What if weight affects blood count? And in fact, it can. Individuals who have sleep apnea, for which the primary risk factor is being obese or overweight, tend to have higher blood counts because, again, they are slightly hypoxic at night. So what if you start combining these factors? What if you take a woman who is in her third trimester, who has a VO2 max of 44 and lives at altitude of above a mile above sea level and has a BMI of 25? Well, the bell curve for that individual actually is very difficult to determine because there probably aren't enough of them, or it'd be very difficult to sample all the different variances in order to achieve that. And pretty quickly, if you start adding in height, you start adding in nutritional status, or any of the other 1,000 factors, well, pretty soon you end up with very tiny segments of the population. So how are you going to have a bell curve with 10 people, right? Or one person? And then just everybody's blood work is normal all the time. So the very idea of very individualized blood work actually is tremendously flawed. We need enough people in the group to make the sampling make sense. We need to be able to find several thousand individuals in that group so that we can decide how average your measurement is. And if it is very abnormal, that is an indicator that maybe you have some abnormal process going on. And that's an important bit to realize, is that in the normal population, in the healthy population, There are some people who measure as anemic because they have athletic pseudoanemia. It is normal for them to run at what the lab will tell you is a low blood count. So the lab itself does not actually tell you whether something is truly unhealthy. It tells you whether it is normal or not by defining normal according to the bell curve of the group. But in fact, an athlete who measures out at a lower hemoglobin is actually healthier because this is an adaptation to exercise so that when that fluid gets pushed into the muscle, the blood still flows easily. It isn't thickened because there was an excess of fluid to start with. So it increases athletic performance. Now that's an interesting thing because if your optimum, and you're not an athlete, is in the middle of that bell curve and you end up on the low end of the bell curve because you had bleeding or you're a woman who had a heavy menstrual cycle or you just donated blood or you're iron deficient or your thyroid isn't working or you don't have enough B12 because you're a vegan or because you're an alcoholic and you're low on folate or any number of thousand reasons why your blood count could be lower than your optimum, you could measure with the same blood count, the same degree of abnormality as the athlete. And in his or her case, that low blood count is actually beneficial. And in your case, it's actually a marker of harm. And this is why individualized labs just don't make any sense. That's not how it works. The whole point of a lab is to compare you to the general population and then try to come up with explanations if needed. And that's one of the reasons why doing a whole bunch of routine blood work doesn't make sense. We often do a blood count routinely. We do a chemistry routinely. We're going to get into that as well. But if your potassium is low, for instance, in order for your potassium to register as low on the lab, your total body deficiency has to be extremely significant because most of your potassium is inside the cell. And we measure only the part of the blood that is in your vein. And out of all the potassium that's in your body, the percentage that's in your vein is actually less than 5%. 95% of it is in the cell. And so by the time the vein measurement portion becomes abnormal, your total body deficiency is quite significant. And that's why it becomes, in some ways, a more reliable lab than something like hemoglobin. My mom, for instance, has a high white blood cell count and has for decades. They've done all kinds of investigations looking for subtle infections, but the reality is that she's probably totally normal, doesn't have an infection, doesn't have any problems, but is on the higher end of that bell curve. She's just slightly over the 95th percentile arbitrary cutoff on what is considered a normal white blood cell count. If you measure enough things in any individual, you will find the one or two things where their normal is outside the normal of the population. So if I measure 10,000 different labs from every bit of your blood counts to your coagulation factors, to your vitamin levels, to your mineral levels, zinc, copper, urine copper, magnesium, intracellular red blood cell magnesium, your cholesterol particle counts. I can measure all kinds of things, your omega fatty acids. Something is guaranteed to be abnormal because the likelihood that you as an individual perfectly align with the population on everything is extremely unusual. That would be extremely remote. Now, there's a whole modern wellness industry that will test you for 1,000 things, find the one where you are outside of the bell curve of normal, and then tell you that that is a problem and you need to fix it. And we have the supplement for you. because we can sell you on the idea that you are outside of normal on this particular lab. But in fact, just like the athlete with the anemia, which is a pseudoanemia, that lower value may actually be more optimum for you. That's an important bit, and I need you to soak that in, because you may take a supplement, get your value into the normal range, and do worse. Or certainly you may not do any better, because your abnormal lab may have been more optimum for your health. That may just be how your body is set up. So unless someone has symptoms that you can track and say very specifically, how is this improving your life? If you have had 20 colds every year for the last 3 years, and then you try starting a zinc supplement and you only get 1 cold that year, and you continue the zinc supplement and you still only get 1 cold per year, and then you stop the zinc supplement and you go back to having 20 colds per year, then you might need to be on a zinc supplement. But for general health and wellness, whatever that means, we may actually be doing harm by normalizing all of your lab values, making you as average as possible. Because that's how these normal values are found, is we find the average and that's normal. And just making everyone as average as possible is not the way to optimize health. So let's talk about a different measurement, sodium. Now, I'm going to geek out here because I think this is fascinating and it's my channel, so y'all are stuck with it. But I will not blame you at all if at any point you decide to skip ahead. I'll put markers in the section below so that you can skip right over the nerd talk here. But sodium, like sodium chloride, is one of the major ions in your blood. And unlike potassium, that's mostly inside the cell, sodium is mostly inside the blood. Some of it is inside your cells, but the major fraction of it is in your blood. And it does a lot of things there. It maintains your blood pressure, it maintains the tonicity of your blood, it maintains the electrostatic charge. But how do we measure sodium? The normal value that a lab will give you is 135 to 145. Some labs say 137 to 147, but the normal value that is usually claimed in labs is 135 to 145. Now, we know that blood can be segmented out into certain sections. You can take all the cells in your blood and remove those, and then you're left with water, protein, and fats. Now, sodium does not dissolve in the protein and fat portion. That is sodium free. Sodium only dissolves in the water portion. Now, if you actually take a very accurate measurement, you will find that in the population, again, the normal values in the water fraction actually is 148 to 159, not 135 to 145. And that is a very interesting thing, because where did that 135 to 145 come from? Well, it came from the fact that the original way of measuring sodium was flame photometry. And this is how flame photometry works, is you draw someone's blood, you spin it around in a centrifuge so all the cells go down to the bottom, and then you pour off the liquid portion. So all the cells are removed, all the red blood cells, white blood cells, etc. And then you're left just with the liquid portion, including fats and proteins, and the water portion. Now, what they found is that if you heat up sodium, it radiates a certain color. Sodium radiates yellow, magnesium radiates blue, so on and so forth. But it's a very specific color. So then you can put a lens filter that only allows that color through the lens. And then you can use a detector to detect how bright the light is coming through that lens. And the more sodium that is present, the brighter that light will be when you ignite the sodium. So basically, they take this fluid, they ignite it, they see how bright, with a very standardized heat, they standardize the amount of heat that's put in, and they measure how bright of a flame, of a yellow flame, they get. Of course, there will be blues and greens in there, but that's filtered out by the lens. Now, the problem is that you can't get plasma, just regular blood plasma, to spray thin enough. It's too viscous. So you have to dilute it. So you add a whole bunch of water to it. Now, it's a very sensitive method. So once you dilute it enough, you can spray it, nebulize it, light it on fire, and you can detect how much sodium is in that diluted sample. And then you know how much you diluted it, so you can divide back and recalculate how much sodium was in the original sample. Now here's the problem, is that you can only dilute with water the water fraction because fat doesn't mix with water. And so you're actually only diluting part of the plasma. Now, fats and proteins usually make up about 7% of your plasma. So in order to back calculate after the sample has been diluted, we just assume that it was 7% fats and proteins, and we were only diluting 93% of it with the water that we added. But in the original methods that were used, they just used the total volume of plasma. So they measured the total amount of sodium and they divided by the total amount of plasma and ended up with a slightly lower number than they should have because they didn't remove that 7%. So 135 to 145 became the normal. The next method that was developed is called an ion selective electrode. So this is how that's set up. There's a sample solution. There's a measurement that only allows sodium through this membrane. So only one of the tubes will end up with an equal amount of sodium as the plasma that's being tested. And the difference in the amount of sodium at each of those electrodes will generate a potential energy. It acts as a capacitor. And that voltage that is detected will tell you how much sodium was in the sample. Now, this also requires dilution. And so you get similar numbers as flame photometry. You also end up with a situation where if someone has more or less fat or protein in their blood, then the method can be thrown off because the method assumes that it's only 7% that's fats or proteins. So if someone has a condition that gives them very high fat counts, familial hypertriglyceridemia, for instance, that will throw off the measurement and you will get a falsely low measurement of sodium because you will measure this much, or you will think you're measuring this much plasma, but all that sodium is not in 93%. All that sodium is now only in 89% or 87%. And so you're going to divide by the whole volume of the plasma and you'll end up with a falsely low number. Now, there is also direct ion, that what I've just described is called indirect ion selective electrode. Direct ion selective electrode is a more modern technique that allows you to not have to dilute. You can just dip the sensor directly into the blood sample. You don't even really have to spin it. You can use whole blood. This is the type of detection that is used in bedside point of care testing. So arterial blood gas kits in the ICU, ISTAT systems, that kind of thing. Whereas the indirect system is what's being used at all these labs because you can process a large number of tubes at once. The direct system currently is limited by the fact that you can only test one sample at a time in most cases. So because the large labs are testing hundreds or thousands of samples, they need to be able to batch them together, and that method is more amenable to that. Now, here's the interesting thing, is that when you use direct ion sensing, you end up with the correct value of 148 to 159 as your normal. 154 is the average. But all of the normal values that physicians are taught are based on the older flame photometry and indirect ion selective electrode techniques. So you would end up needing two different normals because of the test method difference. So instead, they apply a correction factor, and they just multiply by 0.93 to mimic the older, less accurate technology. So the normal value of sodium, even on a modern accurate device that doesn't require any of these manipulations, is recorrected back to the old values because everybody's gotten used to it. Now, you might say, well, don't all the ions have these problems? And yes, certainly potassium and all the other ions have that problem. But it is less of an issue for something like potassium because the potassium bell curve is much wider. So normal potassium is 4.4 plus or minus 20%. A normal sodium is 140 plus or minus 3.5%. And so it's much easier on a lab basis to get the sodium value thrown off by this kind of fat or protein abnormality. And in fact, we do see, by the way, I mentioned fats, we see the same thing in critically ill patients who have a low albumin level. That's one of the major proteins in the body. And so instead of having too much fat, they have too little protein. And instead of 7%, it's only taking up 5% or 4%. And you can end up with a false hypernatremia, or a falsely high value of sodium in those patients. That's much less likely with potassium because by the time potassium is abnormal, it has to be more than 20% out of spec. So that's fine. That's a super technical deep dive into how sodium is measured, so on and so forth. Great. I'm fascinated by these things, like I said. Forgive me for diving in. But even if you get a low sodium value, it does not tell you why. In the modern health and wellness space, you get a low sodium value, and they'll say, well, here, take some salt tablets. But that's not how sodium works. Sodium is a concentration. It's the amount of sodium relative to the amount of water. And in general, when your sodium level is low, it's because you have too much water. That's by far the most common cause. Occasionally, you'll have too little sodium, but that's not always the case. Here's a list of all the different things that can be off with just a low sodium. You can have an error in proteins and lipids. You can have hypertriglyceridemia, like I said. Multiple myeloma will drive up your protein count very, very high, or critical illness will drive it very low. Or you could have been given a medication like sorbitol or mannitol or IVIG. And these medications will shift water from the cell into the bloodstream. Just like I talked about with the athletic pseudoanemia, your body retained water, and because it retained water, it appeared that your blood count was low. Here, you've been given a medication that pulls water out of the cell and similarly drops your sodium level on the lab test low, even though you have a normal amount of sodium in your body. Glucose will do the same thing. So if you have very severe untreated diabetes and your glucose levels are in the 500, 600, 800, 900 range, your sodium will appear low on the lab test. Other things may cause you to retain water. Nausea, for instance, causes your body to secrete ADH, which is your primary water regulating hormone, and you will retain water. Pain does the same thing. So surgical patients that have severe nausea or severe untreated pain will often develop a low sodium level on their blood work because their body is retaining water in response to that hormone, which is secreted as a response to pain and nausea. If your thyroid level is off, you can end up with low sodium. If your cortisol level is low, you can end up with low sodium. If you are a marathon runner and you drink gallons and gallons and gallons of water over the course of a marathon, you can end up with a low blood sodium. So if you have a low blood sodium on your blood work, it is not simply a matter of throwing salt tablets at you and say, well, let's try and bring this back up to the average normal range. It requires thought. It requires deliberation as to why that may be the case. Is this normal for you? Is it a product of something unrelated going on, like uncontrolled diabetes or nausea? Is it a function of a behavior that you've been drinking too much water at a rave where you were on MDMA or a marathon? Or is it a lab error because you have high lipids or high proteins? Now, the same thing you might imagine is true of other things we could measure. Cholesterol, zinc, copper, magnesium. We could theoretically ask similar questions about all of those, except we don't know all of those questions. We haven't studied those as much in detail because their health effects are less acute. Maybe there's no harm in having a low zinc level relative to the population. Maybe there's a laundry list of possible reasons. Merely throwing zinc at you and telling you to bring your level back up to the normal range is a rather thoughtless response, because we know that, at least for sodium, it is a much more complex issue. And if we don't know how complex the issue is, we shouldn't assume that it is simple. So what are the conclusions? Number one, lab tests are intended to trigger thoughtful evaluations when a value is out of spec relative to the population you're comparing to. It is not an answer on its own. You can't just go get a bunch of lab tests and then fix the ones that are abnormal. You always have to keep in mind that the abnormal lab may be optimal for that individual, and you have to think carefully whether fixing that abnormality is going to produce a measurable or important change. I have no problem with running an experiment if your manganese level or your cadmium level is high or low, and you want to run some experiment to change the lab, and then you are measuring carefully some actual health indicator. I don't care what it is, but it shouldn't be a marker. It shouldn't be another blood test. You can't measure the effectiveness of blood tests with blood tests. But if you have fewer infections per year or colds, or if you improve your athletic performance or your diabetes gets better, and we do see with chromium supplementation that it seems to decrease average blood sugars or improve blood sugar metrics for diabetics. And reducing blood sugar for diabetics does reduce neuropathy and blindness and kidney disease. So those can be important things. Now, reducing blood sugar by itself for diabetics does not reduce heart attack, stroke, and death, depending on the method you use to reduce it. So the newer generation diabetic medications like semaglutide, liraglutide, or the LT2 agents does reduce mortality and death because they reduce glucose through other means. But insulin does not reduce mortality in diabetics. It only reduces blindness, kidney damage, and neuropathy. And so tracking the effect of the intervention on the actual person or on a population in a study becomes tremendously important, because merely talking about improved blood sugar control, improving heart attacks, well, it doesn't if you use insulin or if you use sulfonylureas. It does if you use SGLT2 agents. Bringing it all the way back. An abnormal value on a lab may be normal or even optimal for an individual. By contrast, a normal value could be significantly abnormal for an individual. And without doing a randomized controlled trial, it is impossible to say whether fixing abnormal labs for individuals will result in improvements in outcomes, longevity, functional status. For instance, iron supplementation improves athletic performance. We actually can see that. However, it also seems to worsen longevity. So you want to trade off improved athletic performance now for an increased free radical aging process later on? Depends on your goals. Now, that may be true of other things: cadmium, zinc, chromium, magnesium, manganese, any number of things. But we don't know. We haven't studied those things. We haven't studied the long-term effects of normalizing those labs. So we don't know, and in fact could be harmful, like iron. The context of the lab matters a lot. If someone is having symptoms, they're having hair loss, and they're having fatigue, and they're having abnormal menstrual periods, and they're having increased PMS symptoms, then maybe we should look at their hormones. And if we find some hormones that are outside of normal by a significant amount, maybe supplementing those hormones or altering those hormones will result in improved outcomes. But if someone is overall healthy and not really having any problems, then an abnormal lab may just be optimum for that patient. That may be exactly what they need, and fixing it could be making things worse for that individual. The measurement method matters a lot. A lot of these newer labs don't talk about how they are measuring some of these rare or unusual things. And as we've seen, comparing direct versus indirect ion-sensitive electrode versus flame photometry, you can end up with different normals, and you can end up with different effects. Just like for sodium, the protein and lipid content will not alter the direct ion selective electrode measurement. You will always end up with the right value, because it doesn't matter what the fat and protein content is, because the test works differently. It only measures the water fraction. Whereas with the indirect method, which you send off to the lab, it requires dilution, and thus it can be thrown off if the individual is not at the average level of fat and protein content. So the measurement method affects which errors can happen in the lab and why you can end up with abnormal values. The history and status of the patient, their athletic status, their illness status, gender, age, are they pregnant, so on and so forth. All of that can affect normal and what is normal. And similarly, what studies have been done. We've done some limited studies on iron supplementation, indicating, as I said before, increased performance but decreased longevity. But we haven't done that for other things. We've done some studies on hemoglobin, showing that pregnant females have different values, women have different values than men. We've done some studies on body temperature that shows that age has an effect, so on and so forth. But for some of these less common labs, we haven't done any of those studies. So you may be compared to an unfair group, just as if I were measuring your hemoglobin level and I didn't know that men and women have dramatically different levels, and I just used the overall population as my norm. Similarly, we can't individualize labs too much, because the whole point of a lab is to compare to some other group to decide how average you are. If we over-segment, if we talk about race and height and weight and athletic status and gender and age and all the other things, well, we'll end up with a group of one, and you'll be comparing to yourself. And all your labs will be normal by definition, because, of course, your labs are always going to be your labs, and you're always going to be a little older than you were yesterday. So even if I measure and it's different tomorrow, well, I'm older. So if we really segment by age down to the day or the hour, then we're going to end up with too much segmentation. So we really can't individualize lab normals very well. We have to be comparing to a population. Now, ideally, we can find some middle ground of comparing to a population that has enough similarity to you, but recognizing that you will have some differences compared to that population. So for all of these reasons, routine labs for asymptomatic individuals should be considered very blunt instruments. They're good for helping to build a case for disease. So if I measure someone's blood count and they are in the low range, they are abnormal, then the probability that they have some deficiency, some issue, whether it's hemolysis, it's excessive blood breakdown, or they have a deficiency of iron or B12 or thyroid or whatever else, is relatively high, and it becomes worth it to do further investigations, to ask them, well, are you short of breath? Are you fatigued? Are you sleeping well? Have you noticed any tea-colored urine? Have you noticed any easy bruising? What else may be going on? Have you noticed any swelling in your throat or constipation or feeling cold easily? You can ask all these questions and run other lab tests and try to build a case for why you think this person has iron deficiency or B12 deficiency or thyroid deficiency or whatever, what have you. Labs are good for building cases for diseases. They are awful for trying to optimize wellness because you're comparing to a population, and if you don't have a symptom, then the abnormal lab that you measure may be optimum for you. You may already be at your optimum, and you just happen to be outside the bell curve of that lab test. So for all these reasons, I think we need to be thoughtful and careful about how we use labs, especially in the wellness space. I think you'll see a lot of people talking about, well, I measured this lab and that lab, and I measured my testosterone, and then it was low, and I boosted it up, and this and that. But we've not done studies on the effect of any of those things. We also need to consider, and this will be in the next video, how our concept of normal interfaces with our definitions of diseases. So the cutoff for blood sugar is partly informed by the population norm, but if we have more diabetics in the population, then the average is going to shift over time, just like the average body temperature is shifting over time, that we don't know why. But that doesn't mean that the normal values should shift. If we actually see that people develop blindness and neuropathy and have more heart attacks if they are consistently with a fasting blood sugar above 140, then we should use 140 as the cutoff for our definition of abnormal, because that's where we start seeing long-term side effects. That requires long-term studies. So we can't get that information by doing a quick study or by measuring some other marker of inflammation or whatever other nonsense there is. We have to actually watch people and say, okay, you have a fasting blood sugar of 130, you have a fasting blood sugar of 100, and you have a fasting blood sugar of 145. How many of you develop neuropathy or blindness, and at what age? So we're going to get into all of that in the next video. But for right now, hopefully this video has made you think a little bit more about what it means when you see those normal ranges on blood work. And hopefully you have a thoughtful physician to partner with to start to dissect why anything may be abnormal or normal, and to put that in the context of your status and your symptoms to piece together information, not merely react to the flag that comes from the lab. Anyway, till next time. Thanks very much.